How do you evaluate and manage pneumonitis in patients with GI malignancy who are receiving immune checkpoint inhibitor therapy? Pneumonitis is a potential immune-mediated adverse event from immunotherapy or immune checkpoint inhibitor therapy. Signs and symptoms of pneumonitis include shortness of breath, cough, hypoxia. Anytime a patient complains of any of those, shortness of breath, cough, and you note that the patient's hypoxic, which is oftentimes checked as the patient enters the clinic, you will need to make sure you perform a thorough workup and rule out everything while you're working them up for potential pneumonitis. Pneumonitis in these patients is very rare, fortunately. It does occur, but it is very rare. And that being said, you'll want to make sure that you rule out every other potential cause for respiratory issues before jumping to conclusion that it is an immune-mediated pneumonitis. Some of these other potential issues that you will want to evaluate and rule out include disease progression. Many of these patients have lung metastases. Pulmonary embolism. We know that our patients with GI malignancies, particularly colorectal cancer, these patients are at very, very high risk for thromboembolic events. Many of these patients develop pulmonary emboli at some point in their disease trajectory. So make sure you rule that out. Pneumonia, these patients are oftentimes immunocompromised and at high risk for developing infectious type issues such as pneumonia, bronchitis. And another one to rule out would be pleural effusions. These patients oftentimes retain fluid, especially when they get liver involvement with their disease, and can develop pleural effusions as well. So once you've ruled out pretty much everything else, you've determined that the patients do not have disease progression, a pulmonary embolism, pleural effusion, an infectious type of event such as pneumonia or bronchitis, and you do jump to the conclusion and determine that the patient has developed an immune-mediated pneumonitis, you will need to utilize steroids. The recommended dose is 1 to 2 milligrams per kilogram of prednisone or the equivalent per day. And once the patient is improving and responding well to steroids, you're noticing improvement in their breathing, their cough, their oxygen saturation, you will be able to consider tapering the steroids. It is recommended that you start the steroid taper when they've returned to baseline or have had or grade 1 or full resolution of the pneumonitis or the breathing symptoms. Many times too, people will follow the pneumonitis with follow-up x-rays or CT scans if you can get insurance to pay for CT scans as well. But again, very, very, very slow taper of the steroids, especially for pneumonitis, because I will say this is one of the trickier immune events to diagnose and treat, and it also does tend to take longer for resolution. There will be grounds for permanent discontinuation as well. Anytime a patient develops a severe pneumonitis on immunotherapy, that could be single agent or combination, it is recommended that the patient permanently discontinue immunotherapy.